Pleasure to meet you here in your new surroundings, the Bhubaneswar Hyderabad Hospital, and it's such a good feeling to come here. Let me introduce you to Dr. Vani Parmar. She is the Chief of Breast Oncology, and she is decided to talk to us and make us more aware of all the issues that we have related to breast cancer. I'm sure all of you think a lot about breast cancer. Either you had it or you don't have it, but you are scared about it. So we will have Dr. Parmar, who has spent about 25 years, more than 25 years in Tata Memorial Hospital, and has trained people and is like profound in her knowledge about breast cancer. So Dr. Parmar, my first question to you is, how do you like this hospital?
Well, before I start with that, let me say good morning, everyone, and thank you very much for this kind invite for the discussion. Let's hope that we were able to create a lot of awareness in people, and that's what the goal is.
I'm sure you will. So Dr. Parmar, tell me something about the sleep facility which has come up, because it's so new that everybody would first like to know about the hospital and the details that are happening there. Because earlier, these become a big name, especially with the serial that is coming up. Of course, she's done a lot of work, but little was known about it. But now with the serial, I think the popularity has gone 1,000 times more than what it was earlier. So, over to you.
So Punyashlok, Idea Devi Holkar Head and Neck Cancer Institute of India, as it is called, is basically a division of the Can Care Trust, which was created by the trustee, Dr. Gulban Pradhan, Dr. Meher Adavia, and Dr. Roshni Chinoy, way back. Started with one patient donating a small amount of 25,000, which started the trust, and on that, the whole trust grew for the last 20 years, and this is the outcome. We have now an institute that has been developed primarily for head and neck cancers in men and some women, but also addresses the important cancer in women, the predominant cancer in women, which is breast cancer and other cancers in women as well, including gynec and cervical cancer, so ovarian and cervical cancers. So the goal is to obviously address the important cancers predominant in India.
Yeah. I think that's a very good thing, because we've always heard that if we can take care of breast cancer, cervical cancer, and head and neck cancers, more than 50% of our cancers will be taken care of.
Absolutely, absolutely. Because breast cancer itself accounts for about 14% of all cancers in women. And breast cancer itself is that 1 in 4 women will have breast cancer, so 25% incidence, that would be quite a significant number.
Yes. So before we move on to the various aspects of the cancer, you have been in Tata Memorial Hospital for a very long time, and now you've come to a new hospital. Do you find a lot of difference between a private hospital and an overcrowded hospital like Tata Memorial Hospital?
I would say that it's just in the mind that we think there would be a difference, because I think it's finally the patient care that you are able to deliver. Be it a very popular, well-known, long-standing institute like Tata Memorial, which has been there for so many years now and has created its own credibility and status. And I'm very proud of the fact that I was part of that organization for 25 years. And that has given me a lot of insight into patient care. Moving now from a platform which is so busy, as you say, dealing with patients, now moving on to a private sector, it all depends on how you take this forward. So what we are, and the policies that we have here is basically accessible cancer care and affordable hope. That is our theme on which we work. So we are looking at a setup which is completely based on how Tata Memorial has worked. Because most of us who are a part of this organization have been a part of Tata Memorial for a long time. And various time periods in the past, I would say. And all of us have brought in the same ethos and ethics when it comes to patient care. So I don't think we are completely a private sector, because we are working on the same set of principles and policies like Tata.
Yeah, we can see the values at the back, which are written here, that ethics and the excellence in believing in people.
Absolutely.
So, which is the same, I think, for all over, it's the same thing, it should be the same thing for the patient.
Yes.
Okay, so what we thought was, that we will talk in terms of awareness, education, and then the treatment aspect of it, so that it's a complete cycle that is being covered. So to create awareness, what do you suggest? Because do you think people really care about the awareness that is created, or does it instill fear in them and they are not sure whether, especially people in the rural areas, they are really scared about knowing that they have cancer because it has many repercussions. So they don't want to come for a program where breast cancer awareness is being spoken about, especially the women. And so what do you suggest is a good way of creating awareness, whether it is useful or not, and what should one?
So creating awareness alone, when you start with cancer, the first thing is fear that comes into anybody's mind. But if awareness is combined with education, that campaign is going to be a successful one because you're also educating other than instilling fear into people. Fear cannot bring people forward for cancer treatment because they will never come forward early. For them, the diagnosis of cancer itself is a taboo. So to be able to get over that, they need to be educated on how early detection helps to cure cancer. And cancer can be treated like any other condition, any other chronic illness like diabetes and hypertension. So bringing them forward, educating them adequately so that they come forward for treatment early and ensuring cure is going to be our goal. And that is the way it moves forward. So education has to be combined with awareness.
So during this month of breast cancer awareness, I'm sure you've done a lot of work in various, like various strata of society, talking about the education part of it and the awareness part of it. And what has been your feedback on that?
So as far as education is concerned, first awareness campaigns that I have been involved in this month, and this month being the breast cancer awareness month. Obviously, a lot of people are also proactively trying to make people aware. But first thing I must start with, it's not exactly this month. The awareness starts with this month and ends with the next year, the same month. So it's an ongoing process which continues through the year. But obviously, because it is peak October, we are going to be proactively trying to reach out to most people during this month to start the awareness activity. The general concept in people is that I am not the one to get cancer. It is my friend, my neighbor, somebody I know, my grandmother, my mother. The younger generation still seems to believe that they are immune to cancer. And that is one thing that we need to tell them because awareness starts at a younger age. You start from a younger age when you start learning about cancer, how to prevent cancer rather than go treat cancer. So we have to focus more on prevention rather than on treatment alone. Treatment has to be there, it's important. But prevention is better than cure is a terminology which we followed in the last.
See what happens, we've always been conditioned to think that breast cancer does not come till about 40 years of age or something like that. So till 40 people don't, but nowadays we find that even younger people are getting cancer. And so it's important, like you mentioned, that younger generation also needs to change, be aware. So do you think change in their lifestyle is important or it doesn't concern lifestyle?
It does. In fact, breast cancer is one disease which is definitely lifestyle related. Of course, there are various non-modifiable things, like we said, age. And it's been a long notion that elderly women would get breast cancer. Age is one important risk factor, and as age increases, cancer risk increases, and that's seen in most cancers, excepting childhood cancers. But if you look at the fact that just being a woman itself is a risk, but then I wouldn't put men at no risk. Men are also at risk for breast cancer, and that is one surprising thing wherever I've gone. And I've started saying that, did you know men can get breast cancer? It's mostly a surprise reaction. Is it? I never knew this. And that's where I find that the men get interested. Till then, men feel it's a women's problem and I don't need to get involved. So it's not just being a woman. Then there are, of course, various other factors which play a role. But most important is the modifiable ones which we must focus on. The modifiable risk factors are those where we can control our risk for getting cancer.
Yeah, I'm glad you mentioned about breast cancer because normally everybody thinks it's a woman's disease and they will not worry about it. So, is there a relationship in your lifestyle in the villages and the urban areas? Is there a difference that you've seen in breast cancer?
So actually living in villages is really good for us. If you look at the epidemiological data that's available to us, the risk for women living in rural areas is far lower. And we measure these risks as the denominator being number of women completing a lifetime. So if we take it from there, the number of cases versus number of women completing a lifetime in rural areas, it is 1 in 64. The minute you move to a metropolitan city and get involved with the different lifestyle, your stress factors, the diet you eat, the kind of reproductive life you have, all of that put together brings your risk up to about 1 in 28. You're talking about something that's become now really nearly doubled. And then if you look at the West, where it is already an established thing, all this lifestyle is what we are doing is we are acquiring the Western lifestyle. There it is 1 in 8. There is an element of environment also playing a role because somebody who lives in India moves to maybe a Western country will start having a similar risk factor as what you're seeing in US and UK. So there is an influence that is seen with environmental factors as well. In fact, most people believe it is genetic. Most people, if you ask them, say no, it runs in families. So if my grandmother had, if my mother had a breast cancer, I would be at risk. The actual percentage of breast cancers that are genetic is only 5, maximum 10%. That is the smallest. 90% of cancers are going to be related to other features and other factors.
So two things that have come up is one is, because of all the various Bollywood and Hollywood stars were talking about genetics and all that. So a lot of people are going in for genetic counseling and they want maybe as a precaution remove one of the breast or put the breast things like that because they don't want to have the risk of genetic. But you're saying it's only 5-10%. So it's not worth really doing all that, right?
So even within those who have a genetic risk, it's important to counsel them first and understand that it's not necessary that if you have a genetic mutation, you will definitely get this cancer. You're at a higher risk. If you don't have a genetic mutation, it doesn't protect you from cancer. 90% of cancers are going to happen without the risk. So that needs to first sink in. Secondly, having a risk and then doing a mastectomy and a oophorectomy probably will bring down your risk to a small extent. More so if the ovaries are removed. In fact, the risk reducing oophorectomy, as we call it, a removal of ovaries, protects better than doing a mastectomy. In mastectomy, the breast is removed, both the breasts, but there is some amount of tissue still left behind the nipple, in the arm. So there is still a small risk that carries forward. And it is quite a mutilating surgery. So generally, these are not advised unless the patient is, unable to speak, is too anxious, is extremely, worried about her risk, and is unable to take and cope with the knowledge that she has a risk. So these are the patients who are already advised. But if somebody has already developed a cancer and then is detected to have a risk, it changes to some extent impacts on the kind of medical treatment you may have given to the patient. But doing a contralateral on the opposite side breast removal while the affected breast is being treated may not really reduce her risk because her risk is already defined by the cancer which is there. So one has to keep all of these in mind, counsel the patient correctly, and then take it forward. So without counseling to go forward with the treatment based on genetic risk is not really advised.
I think it's a great information that you have shared because everybody, people who are not in the field are actually anxious because they hear or read whatever comes in the newspapers. And I'm sure they will feel more reassured. And also to add that, if one has to do something like that, then ovaries are the ones which need to be removed also because that is where it is.
Generally after family is completed, then we advise.
Yeah, if you have a full family and no more this thing is needed, no more children will not needed, then it is better to have the ovaries removed if you are going in for the risk of genetic
and you are close surveillance for breast. So that the breast is also checked every 6 months. And that can be done by a doctor who can examine or certain imaging that will be used, advised by the doctor, which includes mammograms as well as MRI.
Yeah. So what you are saying is that if the risk is higher, the little percentage, even if it's a small percentage, Is there anything by which you can find out the risks yourself, or you have to keep going to the doctor to do some tests?
There is no method of finding out your own risk except in knowing your history. So knowing your family history is very important to know whether you may be at risk. Now, what is the family history that's important? If there is a young member in the family, say somebody who's only about 25, 30 or old has developed breast cancer or an ovarian cancer, you know that you may be the person who's at risk. So a young member, one first degree relative having a breast cancer. Or if there are two first degree relatives who have say breast cancer or breast and ovarian cancer, then one first degree and one second degree relative. That means your cousin, maternal cousin. Mostly it is mother's side, so maternal cousin, maternal aunt, grandmother. So anybody beyond that, or mother. So any of these having breast cancer, two members, is also a risk. Or there is a male member in the family with breast cancer. That definitely indicates a higher genetic risk. So if you look at male breast cancers, they have more of genetic history in them rather than the female breast cancer. So the women having breast cancer, the incidence is 5 to 10%. In men, it can be as high as 50 to 60%.
But at the same time, you are saying that the risk of having cancer, breast cancer, is it can be for any woman in spite of the genetic. I mean,
because 90% doesn't have a genetic background.
Yeah,
so everyone should be aware of what the risk factors are other than genetic. So it is not only genetic.
Yeah. So what age do you recommend that somebody should start checking up for their breast and to find out about?
So 30 is the recommended age. So at the age of 30 is when you start looking at it. But if you have a say a member of the family who was diagnosed with breast cancer at the age of 30, then you would start 5 years before. That means at 25. No. So the recommended age WHO guidelines is by the age of 30, you have to start doing breast self-examination. And breast self-examination is the best and simplest tool to start knowing your own breast, knowing your normal, and then to be able to pick up what is abnormal.
Yeah. So would you like to just explain the process for breast self-examination?
Yes. So breast self-examination essentially requires that you need to check your own breasts. These are done in premenopausal women, those who are having periods only once a month, 7 days after the periods. So a week after the periods is when you start checking yourself. And that is because the breast is softest at this point of time. During the menstrual cycle, there is a slight collection retaining of fluid in the breast, which makes it very firm. And you may pick up small cysts and other things which are not really important. But after the periods, all of this subsides and the breast actually becomes softer. And that is when it is better to go ahead with the self-examination. In case of postmenopausal women, those who stopped having their periods, they can fix a date, for example, 1st of the month, or 30th of the month, or 15th of the month, or even their birthday, to check themselves. How it is done? It is always done. First, look at yourself standing in front of the mirror. Examine both the breasts to see any similarities or dissimilarities. Whether there's any area the skin looks abnormal, pulled in, nipple retracted, any discharge. Then examining the breast. So left breast is examined with the right flat of the hand. The 3 fingers of the hand is used, and it has to be used as a flat hand, not to pinch the breast and pick them up as loose. So the breast is examined with the flat of the hand. Imagine the breast as a clock and examine in a circular manner, moving radially. That means 1 o'clock, 2 o'clock, 3 o'clock, and each of these you have a circular movement of the flat of the hand. That picks up any abnormal lump or anything that may be there and put it against the chest bone. So you press it against. This whole process is best done in a shower when there is soapy hands, because soap creates a thin film and that makes your finger sensitivity much better. So it's advisable to do this while in the shower. Examination should be done with arms up as well to evaluate the armpit. Feel for that for any abnormal swelling, any lump, any lymph node, because breast usually has an associated lymph node in the arm. Sometimes it can present only with the lymph node, and the breast lesion itself is not fit. So these are all part of examination. And last but not least, to check the nipple for any discharge or any breaking of the skin. Blood discharge is significant, it should be checked. So any of these may indicate. But what one must remember, and most important, is breast cancer may present as a painless lump. Majority, 85% of cases, the lump is felt it is absolutely painless. And these are the lumps, and that is the reason why I've started a handy called lumps don't lie. Because that tells you that a small little lump is telling you that I'm there, that I have cancer. But you tend to miss it, you tend to oversee it, you tend to kind of suppress it, saying that it might just disappear. I don't need to look at it. Maybe if I look at it a week later, it may not be there. But it's still sitting there. If you find a lump of that, then it has to be picked up. Go to a doctor, get yourself checked, get the relevant imaging done with the doctor will advise.
Okay, one thing which is, I don't know whether it's a myth or whether it is really useful, but people like keep talking about, I get my mammogram, मैं तो हर 6 महीने में अपना mammogram करा लेती हूँ, या हर साल में करा लेती हूँ, और या somebody says, पर मैंने तो mammogram किया था, फिर भी मुझे कैंसर हो गया, या breast cancer हो गया, या कोई भी कैंसर. So what is one is that how often should one do a mammogram? And secondly, like is whether mammogram can take care of only the breast cancer. So if you have some other cancer, then can it be related to mammogram, or one should not link the two things?
So mammogram itself is just an X-ray of the breast, done with a low dose radiation, where the breast is compressed between two plates in two directions. So the important thing is it is to pick up any abnormal lump, lesion, microcalcification, which indicates a cancer. So that is why a mammogram is done. It's a diagnostic mammogram. Now, a lot of women undergo mammograms thinking that I'm going to be checking my breast very diligently using a mammogram. The evidence that exists currently is that mammogram is useful only above the age of 50 for detecting cancers effectively. That's because the breast is less dense after the periods have stopped. The glandular element in the breast comes down and the mammogram is able to pick up cancer. Unfortunately, below the age of 50, when the woman is still menstruating and having normal cycles, there is a lot of glandular tissue which is active, and that does not allow a mammogram to visualize any cancer. It can easily be missed in the dense glandular tissue. So the reports would read as dense fibroglandular tissue cannot evaluate lumps or malignancy. So it can easily get missed. So mammogram is not something that you go and get yourself a regular 6 monthly mammogram, because there is no benefit. In fact, it will give you a false sense of security, because my mammogram was normal. So I did not bother to check myself. Whereas there are something called as interval cancers. Even between mammograms, you can develop a lump, and which can be a cancer. So doing a self-examination overrules doing any kind of a mammographic evaluation of the breast, especially in younger women below 50. And majority of our women in India are below 50 years of age. 75 to 80% of them are below 50. So I don't see where mammogram in India is going to play a major role in helping you to screen cancers.
So if I were to sum up, can I say that if some young person in your family has cancer, then you start your breast health examination at the age of 25, so that you don't miss out on anything. From the age of 25 to 30, mammograms don't really play a big part. Breast health examination and your like being aware of when to go to the doctor, because if there is a small lump, then you must not ignore it and go to the doctor. And over 50 years is when you can get your mammogram done, which will be most useful. And you will probably not miss cancer if you do it at the age of 50. And mammogram is only for the breast, and it does not say that you don't have cancer anywhere else in the body.
So I'll just add to this. So breast self-examination is fine, but a clinical breast examination to confirm the findings that you have, because no woman understands her own breast.
Yeah.
For them, this is not something they have been trained to do. You have to get it corrected with a clinical breast examination by a doctor, preferably an expert, who can tell you whether the findings that you're feeling, what you're feeling in the breast is really a significant finding. So for them, it is very important to get it cross-checked with the doctor. So that's the clinical breast examination. And that should also start around the age of 30 and continue from there. So it should be an annual examination at least to find out whether or not you are whatever you're feeling is normal or not. If you understand your breast very well, that's extremely good. Then you can go ahead and do that yourself. But getting a clinical breast examination starting the age of 30 is also important. Mammogram will then be advised by the doctor only and if there is some abnormal finding, a symptom, or any kind of suspicion that there may be a lump or a growth or anything. But after the age of 50 is when doing regular mammograms helps to pick up cancer. So that what is advised is every 2 years to do a mammogram after the age of 50.
I think this should be a really good information for all the people, general people, because there's one fear that everybody has and they keep talking about mammograms and I have to go for this and that and so on. So these excessive can be reduced because if you're in that 30 age group, then there's really no need for it. And 50 plus, definitely no need unless the doctor tells you that you need to get that.
So it's mostly an opportunistic screening as we
Yeah.
call it, that is if they've come with a complaint or a symptom, or if there is something detected during clinical examination, it's a diagnostic method. So mammograms are done, they are part of the workup of a patient, but they don't become your screening.
Yeah. Okay, so simply it's talked a lot about education and awareness, and I think you've clarified a lot of things which people need to know. Maybe we can move on to the treatment aspects of it. And I know there's surgery, there's radiation, there's chemotherapy, so a little about that, and then we move on to the new methods of treatment which are coming.
Yeah, so the standard, of course, is the triple test which is done to diagnose. And once it has been diagnosed with a clinical examination, a mammogram, and a biopsy, which is usually a core biopsy where we take a small little tissue and that is examined for breast cancer being there or not. And of course, the kind of breast cancer which decides what treatment to do. The treatment for breast cancer is always a multimodality. And when I say multimodality, there is a role for surgeons, there is a role for medical oncologists with chemotherapy, hormone therapy, targeted therapy, and radiation oncologists with radiation. So it's always a multi-modality treatment for breast cancer. No one treatment is adequate. It has to be, there is an adjuvant treatment that is added to get the best outcomes. Earlier the cancer is detected, there is a high possibility surgery alone may be required, it may be a radiation, and the amount of chemotherapy to be used or even the hormone or targeted therapy may be lower. But the later it is detected for larger tumors, there is a possibility we prepone the chemotherapy before surgery. So there will be a chemo before or a targeted therapy before. So reduce the size of tumor and then we operate. As far as surgery is concerned, breast cancer is not a sentence for mastectomy or removal or mutilating surgeries. Now there are much more advanced surgeries available. Breast conservation is possible. Breast reconstructions are possible. Oncoplastic surgery, which is nothing but remodeling of the breast using the breast tissue itself, is also possible. And in fact, aesthetic breast surgery is our goal, where we try to give the best outcomes from a surgery with best cosmetic outcomes and use the same for even reducing breast sizes when the breast are large. So reduction mammoplasty, as it's called, is also a very well accepted modality of treatment and safe to be offered for patients, as long as the whole cancer is removed using the oncological principles with a clear margin and the draining lymph nodes are also addressed. So as long as cancer is treated by an oncologically safe and complete method, we don't need to remove the breast.
Okay, so that is one thing which everybody has a fear that I will lose my woman body. You think that अधूरी हो जाऊंगी मेरा तो breast निकालेंगे जो कि बहुत integral part है किसी भी woman के लिए. So if you can live with breast cancer with a breast even after your cancer treatment, I think that will be a very positive thing for a woman, knowing that there's going to be no other hurdle and the cancer will not come back again. And removing both the breasts was what I want to know is when you remove both the breasts, is this plastic surgery done at the same time or it is done later?
So bilateral mastectomy is done very rarely unless there is bilateral cancer, or like I've said, in anybody who's got a genetic risk and is unable to cope with cancer and wants a bilateral mastectomy. If possible, to save the skin and the nipple areola, we do a skin saving mastectomy and a whole breast reconstruction. But sometimes when it is not possible, you may have to use tissue from the body to reconstruct the breast. Doing the bilateral reconstruction is also possible. The breast size may be slightly smaller, but it can still be matched, and the body tissues are only used to recreate and reconstruct the breast. It is still possible, done at the same time as the primary surgery. If for some reason the surgery cannot be planned together, reconstruction can also happen as a secondary reconstruction. That means after 6 months, that is complete all the treatment, complete the chemotherapy, complete the radiation. Then we can plan a reconstruction. So planned reconstructions can happen as a secondary reconstruction. Even that is possible. So women need not go flat with a mastectomy. They can have a reconstruction at any time point whenever they wish to.
You mentioned that you can use the same body tissue. Like if I were to have a mastectomy, then you will use my body tissue. But that will not have cancer cells in it to make it come again.
So the breast glandular tissue. Breast cancer starts in the breast glandular tissue of parenchyma. In such cancers, and when there is no skin involvement, it is the whole of the gland that is removed. What we are reconstructing with is body fat, skin, and muscle from a different part of the body. Majority of the times, it's only the skin, the subcutaneous tissue as we call it, the skin and the fat. Skin and fat in the rest of the body do not have cancer cells. So the cancer recurrence does not happen in a reconstructed breast. It can happen in the tumor bed. That means where the tumor used to be earlier. So the tumor bed, if not adequately treated with radiation, can have a recurrence. Or an opposite breast can develop a breast cancer because there is always a 1% per year risk in a patient who has breast cancer to develop a new cancer in the opposite breast. So that risk remains, and that risk is reduced by giving them other treatment. The hormonal treatment that is given for treatment of cancer not only protects against the cancer that is developed, but also protects the opposite breast from developing a new cancer. So it's a kind of a double protection that they get. Cancer that is developed is prevented from coming back, and a new cancer is prevented from developing in the opposite breast. So tamoxifen nearly reduces by half, 50%, the risk for a new cancer coming in the opposite breast.
And very often we see women having a swollen arm, and these precautions are told them that they should not use the arm when the breast have been removed for chopping vegetables or watering or carrying or something like that. And when they get, when we see the woman with the swollen arms, what is the reasoning? What could be the
So in some cancers that have moved to the axillary lymph nodes, complete axillary lymph node clearance is done. Okay? It is a part of the cancer surgery. Oncologically complete surgery would require all the lymph nodes to be removed. But in very early cancers, the lymph nodes are not involved. You don't need to remove these lymph nodes. It is the removal of the lymph nodes which causes partial lymphatic blockade, or the fluid, tissue fluid from the arm drain to the back to the system. That is the situation where there is risk that if there is any cut, any injury, any burn, any minor injury to the arm can cause this lymphatic fluid to increase in the arm. That's a reaction. It's a reaction of any inflammation. When the fluid becomes more and the drainage system is partly blocked, obviously it will cause arm to swell. Hence the do's and don'ts for these women, that please take care that there is no injury, cuts, especially when you're doing daily routine activities, say in the kitchen, cooking or cutting vegetables or gardening. Any of these normal routine activities which you would not have bothered with earlier can actually cause injury to the arm and cause increased lymph production. So there are various methods now to prevent this when surgery is done. One is to do what you call a sentinel lymph node biopsy. That means cancer in the breast first drains to the first lymph node in the armpit, and if that lymph node is picked up and checked and that does not have cancer cells, possibility that the other cells in the lymph nodes in the armpit will have cancer is much less. So checking the initial 2-3 lymph nodes in the armpit is what we call as sentinel lymph node biopsy. We can even do sampling or axillary sampling where small lymph nodes are sampled, which are in the drainage part. If they don't show cancer, the possibility that rest of the lymph nodes are involved is less and they don't need to have a complete removal. Another advancement that has happened is something called as lymphosurgery. There, the venous system is anastomosed with the lymphatic system. That is done during the main surgery itself, which again helps to drain the lymph fluid into the venous system. Which is okay. So these are all done at the time of surgery. So these are preventive methods. More important is the patient herself is taught physical exercises, arm massage and lymphatic drainage, which she must diligently do after the surgery. So it is done first post-operatively. The day she has a surgery, she rests comfortably. Next morning, she's taught these exercises and she has to do these every day for the rest of her life. So as long as she's doing these exercises, the possibility that there will be lymphatic swelling or lymphedema or swelling of the arm is prevented. So it is a very important step in the recovery phase.
But the lymphedema or swelling is only in the arm, not in any other part of the body.
No, it's only in the arm where the draining lymph nodes have been removed. It does not happen in the other arm or any other part of the body. It's just a physical impedance to the draining of lymph, which we can take care by doing massage and manual lymphatic draining as it's called. So these massages are taught by the physiotherapist in the post-operative phase on the day one. Some of them are taught even before surgery, so that they're well aware that this is what I will start doing immediately post-operative. So the goal is for us to teach it before, but most of the times it happens immediately after surgery. These classes are taken to teach them how to do it.
Okay, we often hear of somebody being ER negative, ER positive, or negative, or so what are the differences in these? And
well, for a day person, let me explain what we're talking about. The tumor is when it is biopsy, we look at two things. What one we're looking at is what kind of tumor, what is the tumor type. Now that decides on the nature of the behavior of the tumor as well. The second thing we look at is the biology of the tumor. When I say biology, this cancer is responsive to what treatment? Does it respond to chemotherapy? Does it respond to chemotherapy and hormone? Or is it going to be purely a hormone therapy responsive tumor? Or does it also need something called as targeted therapy? These are all treatments that we give for cancer. So the ER, PR, and HER2 that you just mentioned is in fact defining the biology of the cancer. And the doctor who was asked for it, the surgeon who was asked for it, will understand as soon as he says this report as to what kind of tumor are we talking about. So the medical oncologist will then plan treatment based on the ER, PR, and HER2. So if the ER and PR is expressed, it does not mean anything. It is not a dangerous thing. It only means that this tumor is responsive to hormones. If it is ER/PR negative and HER2 positive, as we call it, these are treatment given. These are aggressive tumors, so we know the way that the tumor will behave. We know that this needs targeted treatment to make it better. So the minute we give targeted treatment like Herceptin, this cancer starts behaving like a good cancer. So each of these are done to understand the cancer better. Like you need to understand about cancers, we also need to understand the cancer better to be able to treat better. So the ER, PR, and HER2 is primarily to understand the cancers better and to treat them better.
okay, because when we hear negative, then for a layperson it means a different thing, and when we hear positive, then
it is not the same as cancer being negative or cancer being positive. It is more of the character of the tumor, and that's how we take it. And so those who are positive, we have something to target them. So ER positive will have tablets and hormone therapies. HER2 positive will have Herceptin as a targeted therapy. The triple negative cancers, ER is not expressed, PR is not expressed, HER2 is not expressed. So it is called as triple negative breast cancer. Triple negative breast cancer are slightly more aggressive cancers. They also are seen in much younger women. They are high grade tumors, but they are very responsive to chemotherapy. So they are going to be highly chemosensitive tumors. The problem was after the treatment, there is no maintenance treatment for triple negative. But now there is enough research to say there are maintenance treatment even for these kind of cancers, which were supposed to be bad, and it has improved the cancer outcomes. So all cancers, irrespective of what kind, can be treated and they can have better outcomes based on the treatment that we offer them, based on the ER.
So now can be something, earlier it was 50 plus who were, normally assumed to be having breast cancer. And now you mentioned that, 30 plus can also, should be cautious, and even younger girls are, energy susceptible to getting breast cancer. So that means the productive system or the productive age is something that can get affected by breast cancer or the treatment.
Yeah, so going back on the risk factors, see, we didn't discuss one important thing, that breast cancer is primarily a hormone influenced cancer. So early start of periods of menarche and late onset of menopause and increase in the duration of reproductive life has an impact on increasing risk for breast cancer. So there is definitely a correlation between the two. It is not that only after the menopause the cancers develop. Cancers start developing much younger. Now the youngest that I have seen is a 19-year-old with breast cancer. Of course, and there are non-cancer, non-breast cancer kind of tumors also in breast. So some of them happen even in 14 years. The bad, or what we call as a fibroadenoma or a benign lung. But there are certain bad fibroadenomas, these become malignant, they're sarcomas. They can happen at the age of 14, 15, 16. So no age is exempt from some kind of a tumor in the breast. And you need to get yourself checked definitely to understand what kind of tumor is. Now, age and breast cancer. So younger women getting breast cancer has been seen now, and the primary concern of younger women is this is the prime time of their life. If you look at it, this is the time when they would be probably getting married, having children, working, those who are ambitious, they want to move ahead, and they're delaying marriages, they're delaying their first child. All of these will have a major impact on the outcome of women. So younger the cancer develops, age at a very young age has a poor prognostic feature. So it is better to be able to pick them early even in the younger age. And that is the age where you will probably find it most difficult to pick up. Because there are a lot of normal variations in breast that happens with the menstrual cycle, with cysts being palpated, and you may miss a lump. So doing a regular checkup, getting yourself cross-checked with a health provider is very important. So that is how. Second thing is that fertility itself can get impacted. Because young women being treated with cancer, and as I've already told you, it is a multimodality treatment. Chemotherapy is part of treatment. Chemotherapy also affects other fast-growing cells in the body. So it can cause suppression of the ovaries. And if ovaries are suppressed, she will not be able to do childbear. Or if she is a ERPR positive that we discussed just now, ERPR positive and going on hormone therapy. These are tablets which have a teratogenic effect on the developing baby. So pregnancy is not advocate. So having children and having a family becomes a little bit of a concern. So there are various methods that we need to follow to preserve the function of the ovary while chemo is being given. And that is how we manage to maintain fertility in the young women. Younger the age, even though age is negative impact, that is younger the age, more the prognosis, the ovary may not be that affected with chemotherapy. She may still be able to conceive after chemotherapy. So there are various nuances to breast cancer. No breast cancer is similar. No two women with breast cancer will behave similar. So never try to decide what your outcome is going to be based on what the other person went through. So do not try to take home a message that if I saw somebody going to chemo, I'm not doing well, I will also not do well. That's not the thing. You may not need chemotherapy at all. If you maybe reach earlier to us, we detect earlier, we may not even give chemotherapy for treatment. You may be able to avoid completely. So the various side effects and toxicities we have been discussing may not be applicable to you at all. So this is something that we must bring forward. Education regarding cancer is extremely important to understand, and cancer can be cured. And I think that's something that we must take from every day.
Yeah, so just like even looking at sperm banking for men, is there something like an over banking for
Yes. So certain women who could say diagnosed young, have recently got married and have got diagnosed with breast cancer, they would like to have preservation of their ovarian function. One method is, of course, is to give them an injection with the chemotherapy to suppress the ovary, so that the ovary is not, as I said, rapidly dividing cells get exposed to chemo and they have side effects. If you make the ovary quiet and not have a rapidly dividing cell, in that situation they will not be required to do anything else. Just that injection would suppress the ovary. So these are injections given to suppress the ovarian function and not to have and regain the ovarian function back as we saw. The second, as you mentioned, like sperm banking, there is something called as the ovum banking also. So they can be egg harvested. For that, there is a mild stimulation given to the ovary so that there is an ovulation. These are then harvested and they are preserved. They are cryopreserved till she's ready to conceive. Now that ready to conceive is also based upon what kind of treatment she's getting for cancer. For example, a triple negative breast cancer woman can maybe attempt to conceive after 2 to 3 years, because her highest risk is the first 2 to 3 years. After that, she can go ahead and attempt pregnancy if her periods are normal again, or if we are able to do banking, home banking. The better is to do a oocyte banking. That means if there is a sperm available, she has a partner, this ovum is fertilized and the oocyte is preserved. The life of preservation of an oocyte is far better than an ovum. So the success rate here may be only about 60% to 70%, not 100%. And ovum that is harvested and kept in preserve, the success rate may be even lower, maybe only 30 to 40%. So it all depends upon what has been harvested and what has been preserved. Secondly, it's also an expense involved in preserving these. It's not just a matter of harvesting and keeping. There is, it's like when you keep something in the bank, you have to, there's a time period. Yeah, I mean, you put your own money in there, but here you are now borrowing the space to keep something in safe locker. So it's like a locker. You have to pay for the locker. Similarly, here when you have harvested an ovum on a site and you're preserving it for a time period, there will be a cost incurred for a year. And these will of course be based upon where it is done. The cost will increase if somebody is here positive because you have to preserve it for that much longer. So the first attempt at pregnancy will be at 5 years, or after they have crossed the 4 to 5 year period in a ERPR positive person, because they will go on to tablets. I've told you, tamoxifen is teratogen. If tamoxifen is going on, pregnancy cannot be attempted, and it can cause harm. So after 5 years is when we will allow her to get pregnant. When we discontinue the tablet, give a washout period of 3 months and then allow them to get pregnant. A normal pregnancy can happen even after breast cancer.
Yeah, that's what my next question was going to be. Suppose somebody has not preserved anything and whatever it is and all that, and the treatment is over. So after how many years? After 5 years? Is she not?
So the highest risk period in a cancer for a recurrence is in the first 2 years. 18 months to 2 years. So if the 2-year period is crossed and no recurrence has happened, the first risk has been taken care of. A triple negative breast cancer has the highest peak of recurrence risk, and that is in the first 2 years. If 2 years have passed, we can allow her to get pregnant after that, based upon, of course, her primary disease and what is the risk that she carried and how much risk she carried forward. So it's best to ask the doctor. Your treating oncologist will tell you what is your risk and can you now go ahead and attempt pregnancy. And if the periods have started because ovary has been preserved and normal periods are there, she can conceive it. If it is an ERPR positive tumor, it's a slightly better outcome compared to triple negative. The risk is still highest in the first 2 periods. You cross the first 2 periods hurdle. Now is the time when you can think about conceiving. But tamoxifen or the hormonal treatment that we're giving, or anti-hormones are they called, do not allow a pregnancy to be safe because they can have teratogenic effect. So normally in such patients, we wait for 5 years. At least 5 years of treatment over. So at 4 to 5 years of treatment, we give a break in hormonal therapy. 3 months break after that. 3 months washout. Then, if the periods are normal, they can start to attempt a pregnancy. They can have a safe pregnancy. Baby is not affected. There is no harm to the baby. The pregnancy itself does not affect the mother. She doesn't have a higher risk for cancer because she has taken a break. There is evidence and studies now to show that breaking treatment at 5 years and giving that little 2 years of break while she conceives 9 months of pregnancy and delivers with 3 months of breastfeeding, that time period does not negatively impact on the mother. So it has been shown in studies. So it can be done, but yes, this has to be decided by the treating doctor based on her inherent risk. So each individual patient will have their own risk calculation, which is done based upon how the primary tumor looks.
So to take one is that normally you wouldn't want to, I mean, wouldn't you know that you need to preserve your ovum or like a sperm in the thing and then keep it for you till you know that you have breast cancer, right?
Right.
So will that breast cancer have already affected the ovum?
Not really, not really. It doesn't directly affect unless she carries a genetic risk.
Okay.
Now, as I already mentioned, who are the women who have a genetic risk? We can make out from their clinical history. So if there is somebody who has a very strong clinical history of breast cancer in the family, or we call hereditary breast cancer, or has tested positive, then doing an ovum preservation, you will really need to have more genetic studies on the ovum also, because we may carry it forward. But such tests are available, but they're very expensive, and so it is in that situation. I think it's more of understanding that you may end up having a child also carrying a risk. So that has to be understood. But like I've said, for the same, whatever applied to you applies to your child. So if you have carried a risk and you have managed to live to the age of 35, 40, have not developed breast cancer, have now developed, I think it's not right for us to stop such a pregnancy from happening. The main important thing is educate the child also that they have to start being alert, they have to do self-examination at the right time, be under proper surveillance, detect the cancer early, and be cured of it. So, as I said, having a genetic risk doesn't mean that you will not be cured of cancer.
Yeah.
You can be cured of cancer, but be aware and alert that you can have a recurrence, you can have second cancer. So, these are things that one must keep in mind. It does not mean you cannot have a child.
Yeah, but what about breastfeeding?
Breastfeeding is absolutely safe. We avoid chemotherapy for a person who's breastfeeding. That means we avoid breastfeeding for patients who are on chemo, that we put in the right way. So because sometimes these drugs can pass down to the child and can affect their system. Other than that, breastfeeding itself does not transfer or transmit the cancer. Breastfeeding is absolutely safe. It is good for the child, good for the mother to bond, and it is not contraindicated. But the breast that has been operated on with the conservation done and the radiation given, the milk production may be low. So that breast may not be useful for feeding the child or feeding the baby. Also, there can be discrepancies in breast size that comes in because of one-sided breastfeeding. But these all involute or reverse back after lactation is stopped. So these are things that are a woman must understand and accept. But breastfeeding is absolutely safe and should be done.
Okay, suppose it's a very hypothetical question that suppose a woman has a child, no breast cancer till then, and has fed the child on from her breast to her belly, and after about 2 months or 3 months, she comes to know that she's got breast cancer. How would it affect the child?
So, like I said, it doesn't make any difference. This is also called as a pregnancy associated breast cancer. She might have had a small lump during pregnancy which she didn't detect. Maybe it was there afterwards, and because she was lactating or breastfeeding, her breast had become engorged, that lump could never be fed by her. So, this is a pregnancy associated breast cancer. It needs to be treated like any other cancer. There is no difference.
No, but
So,
the child has
for her, it is the same. For the child who's being breastfed from the same breast.
Yeah.
As I've told you, there is no cancer that is transmitted through the duct, through the milk to the baby. So it does not affect the child in any way. We may then stop lactation only because we want to do a treatment for the lump. Especially if you are trying to do a conservation of breast, we'll have to stop the lactation. Not because the child cannot be fed the breast. No. And expressed milk also can be fed to the child, it does not harm the child. So essentially, cancer does not have an impact of or does not transfer through milk to a child.
So we've talked a lot about women, you know, the symptoms and the signs and all that. But what happens to a man? I mean, the same things. Can a man reproduce? Can a man have problems? How does he detect? Because how will you know from his breast?
Very good. So we talked about incidence. We said, yeah, males do get breast cancer, and 1 in 100 cases would be a man. So the incidence is thought to be 0.5 to 1%, is what we know in the incidence in men. It's small, yes, but it doesn't exclude them from being diagnosed with cancer. A man with a breast cancer would be treated the same way as a post-menopausal woman with breast cancer. So that is how they are treated. So their treatment also includes surgery, which in majority of cases would be a mastectomy. Because the breast is very small, there's nothing much that you can save. Exceptionally when men have gynecomastia or enlargement of the breast. In them, a small tumor you can still treat as a just excision of the tumor itself. But mostly when we have a mastectomy, in fact, one step ahead, they will have a radical mastectomy. Sometimes the underlying muscle is so close to the tumor, we may have to remove that as well. Axilla is also treated in the similar manner. That means a clearance is done, especially if it is a mastectomy or a large tumor touching the muscle, all the lymph nodes should be removed. As far as chemotherapy and hormonotherapy, everything is similar to it. So chemotherapy is also given to men. So they will also have the side effects of loss of hair, loss of testicular function. So there will be impotence that will happen after chemo. And after that, the recovery that happens, sometimes it comes back. So there would be fertility that would be affected in young men with breast cancer. In men, it is mostly the middle-aged to elderly who develop breast cancer. Young men with breast cancer are not that common. As it is, it's a rare thing in men. So within them to have young men will be probably an occasional one or two. I've had patients who have been 24, 25. In them, you have to talk about then sperm banking. So sperm banking is much easier to do sperm banking before they start chemotherapy. So that is something that follows. So everything is the same that we talked about for women, we talk about for men. The only difference would be for probably the hormonal treatment. They are treated like postmenopausal women, but their hormonal therapy is like premenopausal.
Oh,
So the rest of it follows like a postmenopausal. But the hormonal therapy would be like a premenopausal, they're given tamoxifen. And if they have to be given other hormonal therapy, sometimes oophorectomy is not appropriate. I'm sorry about that. So removal of the testis is advised in some patients because you need to change the hormonal. So there's a lot of similarity in cancers in men and cancers in women. There is something that we need to understand that these are cancers which may be even more aggressive in men, but majority of them would be hormone sensitive, so they can go on hormone therapy. Chemotherapy still remains a part of treatment for both.
one last question on this is that if you are nowadays most people either believe in having no kids or just one child.
Yes.
And does it affect the probability of your getting breast cancer or it doesn't matter?
Smaller the family, smaller the lesser the number of children, lesser the number of pregnancies, your risk for cancer goes up. But that doesn't mean that you can advise somebody to have 3 children and 4 children in today's generation when they're working women, having one child itself is a break from service. And that itself is very difficult to cope with, and you want to get back to you want to grow in your job, you have ambitions, and you want to be there at the highest possible level. So obviously everybody restricts their family down to just one child. Even breastfeeding that child is a break that they need to take, and that also is limited with the maternity leaves that they get. So there's always a problem with women and children and family. But it's advisable generally to have 2 children at least, have them before the age of 30 to have the best protection. Completed pregnancies protect, abortions do not. So it's not like you can have, conceive 2-3 months later, get an abortion done and you get protected. No, it doesn't protect you from cancer. So that's not a remedy for cancer either. So these are, I'm just saying because people would think that I had 3 abortions, so can I be, then am I safe, but I didn't have a full term pregnancy. No, it's a full term pregnancy which protects, but not an incomplete pregnancy.
Yeah. But it's been a really learning experience as far as cancer treatment is concerned. And I think I've always covered everything. But one thing is there anything else that you would like to talk about before I ask you the next question?
Yeah, sure. I mean, see, basically, what we can do for the patients, we can do better only when organizations like yours and patient organizations can come forward and help
You
us.
still ask a question which I have got in mind to ask.
Because I feel happy about thanking you all for all the help that you have always done with the patient. And that's the reason why. So go ahead and ask. I'm not going to say that.
I wanted to ask you about your support groups, what you feel about them. Do you think that people should be more trained while they're talking and not just saying because I had something, like you mentioned, that 2 people are different. But sometimes people volunteer get carried away and they say, मुझे भी हुआ था और मैंने ऐसे किया था. So what are the type of things that you want from a support group? I think that's important for people.
Yes. So the best person who can take care of another patient is a patient person. Because the experience that she has gained out of cancer treatment, recovery from cancer, the whole emotional turmoil that goes through her, all of this is best understood by a patient survivor. They are called by various names, victors, as you would call it, yes, some call them thrivers, but these are the people who know best how to hold hand and take the patient forward. So the hand holding is best done by them. And we as a healthcare organization, I think without the support that we get from all of you, would not be able to do a comprehensive cancer care treatment at all. To take that further, unless that person is also taught and educated on cancer, our own experience does So a negative experience may carry forward as a negative, counseling. But if it is done with a proper understanding and education, so that is where not just awareness, education and awareness has to be taught together. And that is best done by the organizations, patient organizations who are there. So all voluntary organizations that I work with, I also make it a point to have discussions with them and converse with them on cancer and cancer treatments, advances in treatment. Everything should be known to them because when they are talking to a patient, they should be able to convey in a very intelligent way what is important for them to know. And to understand the side effects better, you must know the effects. And why is the effect so important for the side effects to be tolerated? So I think it goes hand in hand.
So, can you say that your team should be doctors, surgeon, medical oncologist, radiation, and a support group?
Absolutely.
So, why don't you add that in the group?
It is always in the group. It's always there in the group. In fact, we reach out to the support groups every time that we have a concern with any patient. So every organization now has a support group within their system. And it's not just one support group. There are so many patients and there are so many support groups. And I think it's very important for all patients to go through this. And the best, as I told you, is a person. You are part of our ecosystem. Without you, we don't exist.
Thank you for saying that.
Yeah. No, that goes without saying. I have seen in the last so many years that every time I have needed some help, I've always reached out to the support groups and the voluntary organizations. And I think they go a long way in helping a patient to walk through the journey comfortably and to come back out of it as a victim. So I think that really stands there.
One last, absolutely last, promise that we often talk about using prosthesis for the breast, and then people say that I mean they haven't had a artificial, they haven't had a breast reconstruction done, and then they are in two minds because whether they should use a prosthesis or not. One, the second is what type of prosthesis should they use. And what is the benefit that they're going to get out of using the prosthesis?
So there are various kinds of prosthesis. First of all, using the prosthesis is beneficial. It is not harmful. It doesn't cause any harm. It doesn't heal completely. One, it is aesthetically improves the body image. Secondly, nobody comes to know that they've had a mastectomy or a removal of the breast for cancer. Thirdly, it also helps to balance their. So otherwise, they develop chronic backache, postural deformities, and these are corrected by using the correct kind of process. So identifying the correct kind of processes is very important. And again, there are the rehabilitation departments in the hospital, the physiotherapists, they will be able to guide on the exact kind of processes that suits them best. It all depends on your habits. So a person who has got an average build, small breast, they can use even a lightweight prosthesis. But an average build person, somebody who's a little more heavier would require a different type. But the ideal one is to use a silicone prosthesis, which is advised. There are various alternatives available to people who can't say afford them or have access to them. In some situations, they can use other alternatives. But the ideal thing is to get a weight matched prosthesis. Contour matched and a weight matched. And I think the best person to give you this advice is from the rehabilitation departments. They would be able to, occupational therapists as they call it, some physiotherapists also help you. So they are the right source. And of course, I know that a lot of voluntary organizations also help patients to get this. This is, fighting back, coming back to your normal living, normal life all over again. So cancer can cause a little, comma in the sentence. It may be a small full stop for some, but it definitely is not the end of the sentence. There is something that you need to write beyond, and I think that's how we take it. So all of these are where you put the punctuations and how you place the punctuations, and I think that's how we take life forward.
Thank you very much, Dr. Parmar. I think it's been very educational, and I'm sure our audience would have benefited from the whole thing. And I'm sorry for taking up so much of your time, but it's good because so many people will benefit out of it, and they can watch it on our different channels, and we recordings will get there also. So You may have a lot of people wanting to know more. If there is something like an email that you'd like to share it now, or can you share it?
So I will, so my email is dr.vaniparmar@gmail.com. You can, so it's all in small letters, dr.vaniparmar in full name @gmail.com. If there's any query that you have or any question that you have, you may email, and I would take time out to answer whatever is possible. Ideally, an examination or a checkup is better than just asking on emails, because it's a physical examination. You can also learn how to do a breast self examination, be guided correctly how to do the breast self examination. But whatever, it is important to still understand that being aware, being alert, early detection still takes the icing, the cherry on the cake, because you really have to pick the cancer early. For that, you have to know your norm. And this I repeat again, because this is important, and that should be your take home message as far as possible.
No, there will be one more take from this. What about the diet? Because that's a big thing in everybody's mind. You've got cancer, you've got breast cancer. So what is the diet?
What do I eat that I don't get cancer?
No, what do I eat? Okay, what that I don't get cancer, and what do I eat after I get cancer? Both.
Yes, so healthy diet is very important, and I think maintaining a healthy diet pattern is extremely important to prevent cancer. It's not one thing that goes with it. So physical exercise, timely food, and ensuring that none of the junk foods are eaten. These are all cause obesity, and obesity is a very high risk for cancer. So preventing obesity is also very important. So I guess it's all of these put together which play a role in, I know, what is your evaluation. So a healthy diet, and after cancer is there, again the same, it is a healthy life practices, as much of fiber in the diet, avoid alcohol, avoid smoking, all of these are important. Avoid high estrogen containing foods, so these are important for preventing cancer. But most important, maintain a physically active life, exercise regularly, and exercise, maintaining the body weight down, prevents cancer, it prevents recurrence of cancer, and it also ensures that you enjoy life to the full.
Thank you very much. Definitely the last. No,
That's an enjoyable discussion. Thank you, as always.
and
I hope we have helped the everybody by understanding cancer better.
so yeah,
Thank
and
you.
that's so much learning from you. So thank you.